Dear committee, dear audience, my PhD topic is about teledentistry in the diagnosis of oral lesions. My name is Eszter Uhrin and I work at the Department of Community Dentistry. My vision is a teledentistry application, and my mission is to use teledentistry in the diagnosis of oral lesions in the primary dental care. In order to complete my mission, here are the following specific goals. My first project is about teledentistry as a future solution in the diagnosis of oral lesions. Healthcare had a lot of change during the last 3 years. However, telemedicine could help in various fields, for example, in the air triage system and also real-time data analysis. In Hungary, during the pandemic and during the lockdown, the non-urgent dental cases were decreased, as we can see with the orange columns here. However, urgent cases remain the same, as we can see with the blue columns. These non-urgent cases and follow-ups also needed some solution, and teledentistry could help in various fields as well, store forward and real-time solutions. The incidence of oral cancer is rising nowadays. The main risk factors are smoking, tobacco chewing, and alcohol consumption. Tobacco chewing is very common in the Far East, as we can see in the pictures, for example, in India and Malaysia. My aim of this investigation is to see the opportunities of teledentistry in oral medicine. So my clinical question is it possible to use teledentistry tools for diagnosing oral lesions? We conducted our systematic search and found 10 eligible articles. Conducting a diagnostic meta-analysis, we used the diagnostic accuracy measures, and we concentrated as an index test for teledentistry, and our gold standard was clinical oral examination. And I would like to emphasize that the false negative rate was the main outcome that we wanted to decrease. So our first outcome is about the diagnosis of presence of the oral lesions with teledentistry tools. With a sensitivity of 0.92 and specificity of 0.93, we can conclude that with teledentistry tools, we are able to diagnose the presence of oral lesions. As our main outcome, we investigated the diagnosis of premalignant or malignant lesions in the oral cavity, and we could make a two-dimensional analysis, and our pooled estimated sensitivity and specificity is shown here with a relative small confidence interval. As it is on the forest plots as well, with 0.93 and of sensitivity means that if we have 100 premalignant or malignant lesions, 93 out of these 100 are well diagnosed as true positive ones. And in case of specificity, 99 lesions out of 100 lesions are diagnosed as a true negative. So we can conclude that teledentistry tools are able to differentiate between premalignant malignant lesions and non-malignant lesions. We also made a sensitivity running, and I am showing here the forest plot of this outcome. We got even better sensitivity with 0.95, and the specificity is about the same. As a summary, the strength of the investigation is that the diagnosis was made only by experts, and however, the limitations are the heterogeneity of the methodologies. As a conclusion, teledentistry might be a good substitution for face-to-face dental visits in the field of oral medicine. However, there is an implication for practice. A photo shooting protocol would be needed in the clinical practice, and as an implication for research, the reference standard should be changed from clinical oral examination to biopsy. I'm happy to announce that our article was published in the Telemedicine and eHealth journal. My second project is about the effect of oral healthcare prevention program on post-stroke patient oral hygiene and level of oral opportunistic pathogens. Stroke is the single largest cause of disability nowadays. However, there is no worldwide protocol for treating them, nor the nurses nor the dentists are well prepared for them. A stroke can cause a disability. Not only personal hygiene, but oral hygiene can worsen during their rehabilitation, as we can see here. However, just with a little help, for example, personalizing toothbrushes, we could help to maintain acceptable oral hygiene during their rehabilitation. Aspirational pneumonia occurs in every second post-stroke patient, and also with the worsening of oral hygiene and with the swallowing disability, oral opportunistic pathogens become the dominant of the oral microbiome. So our aim is to investigate and to prevent the worsening of oral hygiene, thus preventing tooth loss. And we want to investigate if personalized oral healthcare prevention program must be part of the post-stroke rehabilitation. So my clinical question is there a significant difference in oral health status in post-stroke patients if they receive oral healthcare prevention program? We conducted our systematic search, and our first outcome is the plaque index, which we can see here that in a 1 month time point, we could reduce by 2.77. And at a 3 month time point, we could reduce they could reduce plaque index by almost 5. As diving into the oral pathogens, we investigated first the yeast, so Candida species, and we found the risk ratio was about 1 at short-term evaluation and at 3 months time point as well. So this is nor clinically nor statistically significant here. Our second oral pathogen group was the gram-negative bacilli. We found 0.77 risk ratio at the short term, and at 3 months we found 1.04. So we see that short-term evaluation might be clinically relevant, however, statistically not significant. And our last one is about Staphylococcus aureus, which we found 0.98 at the short-term evaluation, and at 3 month time point we found 0.74. The strength of this investigation is that we included only RCTs. However, the limitations is that there is no significant change in oral opportunistic pathogens, and that the prevention program differed, and also the controls. To conclude, personalized oral healthcare prevention program should be part of the rehabilitation program for post-stroke patients, and also there would be needed a comprehensive protocol for them. As an implication for practice, we suggest a monthly oral healthcare prevention program to prevent the worsening of oral hygiene. For example, a dental hygienist in a stroke unit would be needed in the future. As an implication for research, control groups should not receive any kind of oral hygiene education in the future. As a summary, I have these 2 ongoing projects, and I have some additional activities as well. I am part of the patient care at the Department of Oral Medicine, and I also made lectures on teledentistry in oral medicine during the pandemic, and also about interdisciplinary teamwork in oral medicine. I also attended 2 conferences in the last 2 years, and we conducted a survey about the use of teledentistry among Hungarian dentists. I would like to thank you for your attention with this quote: "Be the change you wish to see in the world," from Gandhi. Thank you.
Congratulations for your presentation. Regarding your first project, I wanted to ask that, as I remember correctly, in your PICO, you included as a comparator both the reference, both clinical assessment and histological results. But you mentioned later, I think, that the studies only used clinical assessment as a reference, right? So how can you conclude that the system could differentiate pre-malignancies from malignancies when, based on the clinical assessment, I'm not sure that's feasible?
Thank you for your question. Well, in oral medicine, basically the gold standard diagnosis is just clinical oral examination. However, and we can predict if if an oral lesion is premalignant, malignant, so it is one group, and the other group is like non-malignant, for example, a fibroma or whatever. It is visible. However, in case of malignant lesions, when they thought, there were some articles when a specialist thought that histological evaluation is needed as well, so it was tested histologically as well. However, we had to include that clinical oral examination because most of the studies use this kind of gold standard. This is a problem, and we would like to emphasize that this is not a good gold standard, but because it is visual. I mean, we cannot predict if it is a premalignant, malignant lesion or just a non-malignant lesion.
Congratulations, sir. I have only one question. That could you differentiate the oral lesions in the population, or did you do some subgroups, or were you just pulling everything together that these were suspected oral lesions?
Thank you for your question. So first of all, we wanted to investigate like normal populations, as you can see in our PICO. However, we faced the situation that most of the articles dealt with suspected oral lesions. So that's why in our first outcome, there is just 3 studies. The Birur study was conducted, for example, in a factory where they were screening every worker there. So this we can say that this was like some kind of population, and Haron made also an evaluation of, let's say, suspected oral lesions. However, here in these 3 studies, there were some people who did not have any oral lesion. That is why we needed to investigate separately these articles where the population was basically people with oral lesions that went to, for example, they went to a dentist, or they just called the dentist, or what they thought that they have something in their mouth. So we differentiated between these 2 groups.
Thank you very much for your presentation, and congratulations on your accepted manuscript. Just for me to understand it again, so if I understood you right, you said that some of the malignant or pre-malignant lesions are then just diagnosed as a malignancy or as a cancer just by a visual examination? Or is it in dentistry this case? Is not everything sent to pathology to have a 100% confirmation of this idea?
Well, let's say mainly it is the first diagnosis. I mean, if somebody goes to a primary dentist or a general dentist, to the GP, then they see some kind of oral lesion like this or like this, and they send the patient to an oral surgeon, a periodontist, or an oral medicine specialist. So they are just visualizing that this might be a cancer, but this might also be a cancer. However, if they see this kind of lesion, that they might think that, okay, this is not a cancer, but I don't know what this is. But mainly, let's say in low-income countries, they might not have the support to make the biopsy of every single case. So that's why the first, let's say, pre-diagnosis is visual. I mean, when somebody arrives to the oral medicine department of the Department of Community Dentistry, we always ask about the anamnesis, and also we try to figure out what is the cause of a lesion like this. We don't tell to the patient because we think that the true diagnosis is by the biopsy. So we are waiting that 3 weeks for the biopsy examination and the true diagnosis. But we are thinking as well about, okay, this might be a leukoplakia or this might be a carcinoma, but there is not a consensus. I mean, not yet.
Thank you very much. And if I may ask one more question.
That's why we are here.
I assume one of the main or biggest benefits of this teledentistry would be saving so economics reasons and time-wise as well, so saving money and time. I know this is not your analysis, but maybe while you read your studies, have you read anything about this? How much time, how much money could be saved effectively there?
Well, originally we wanted to investigate this aspect as well. However, it would need further studies and more studies that include this. For example, there were some studies where they differentiated the people who came to the specialist. So between 0 and 50 kilometers, between 50 and 150, and more than 200 kilometers. So it is cost effective and time effective. However, we don't have data. Objective data on this, unfortunately. And also because of the pre-triage system. So for example, if somebody has like cheilitis actinica, then this could be treated also in the primary dental care. I mean, this is not a big deal. It needs a follow-up every 3 months or 4 months, but we are not taking this one out. It doesn't need a surgery. So if this one is not referred to a specialist, which is, I don't know, in some cases, for example, in India, it would take 200 kilometers to arrive to a specialist, then it can be used as a pre-triage system and also save us money and time.
Okay. In case of your first study, could you explain us the sensitivity running forest plot?
Excuse me, the
sensitivity running forest plot. What is it?
So we conducted the sensitivity running with the two-dimensional analysis as well. However, I wanted to show it on the forest plot because it might speak a little bit more to the audience, but because we are more we are more familiar with the forest plot. However, we conducted the sensitivity running here because in some of the studies, there were two examinators, teledentistry examinators, and we chose randomly the one. In the sensitivity running, we chose the exact others, and that's why we got different values here. It is... with the Tamás, we decided to make the two-dimensional analysis primarily, and then those data are represented on the forest plot. So this is not an original forest plot statistics, but the two-dimensional analysis is visualized here.
So this is not a sensitivity analysis, but a two-dimensional analysis.
Yes. Can I... So this one is the original.
I start to understand.
Okay.
Thanks. Okay, my other question, it's not a really statistical question. If you go to the second project, to the clinical question, I just want to ask if Peter Hegyi agreed with this question as a clinical question.
Well, yes.
Did he accept it?
At least he didn't say that this is not correct like this.
Okay, this is not a clinical question.
Okay.
This is a statistical question.
Okay.
Okay, yeah. And my third question is concerning clinical relevance. You said in case of one of the forest plots that it's clinically relevant but not significant. What is the basis of this statement? Well,
we can measure the plaque index between 0 and 3. So with the minus 2.77, I would say that this is clinically relevant. However, because we use standardized mean difference and the confidence interval passes the number 0, then this is statistically not significant, unfortunately.
Yeah, and what is the meaning of this confidence interval?
That the study population, I mean, if we see an average, then the study population is between this minus 6.6 and 1.06.
No, the real pooled difference is between these two values. So if you say something, I should say this because I've heard so many times this was wrong. So if you say about something that is clinically relevant, you should always see the confidence interval, not the point estimate. Okay, so in this case, it's 1.06 or the other side.
Yes.
So, okay.
Okay, thank you.
Okay.